Kidney diseases can result from dysfunction of any part of the kidney. In this section, we'll talk about diseases that result from dysfunction of the glomeruli, called glomerular diseases. Nephrotic syndrome is characterized by massive proteinuria, that is spilling of the protein into the urine. The standard cutoff for this is about 3.5 grams per 24 hours. What happens in this disease is proteins that are normally not filtered at the glomerulus, they remain in the plasma. For some reason, the glomerulus doesn't work properly, and the proteins are able to cross the basement membrane and enter the urine. The consequence of this is hypoalbuminemia. They spill so much albumin into their urine that they have very little left over in the plasma. This leads to decreased oncotic pressure and often massive edema. Patients with nephrotic syndrome also develop hyperlipidemia and hypercholesterolemia and often find themselves in a hypercoagulable state with a tendency to form clots, thrombosis in the vascular system. Now, there are 6 basic categories of nephrotic syndrome diseases. These are minimal change disease, focal segmental glomerulosclerosis, membranous glomerulonephritis, membranoproliferative glomerulonephritis, diabetic nephropathy, and amyloidosis. We'll consider each of these in turn. Minimal change disease is frequently seen in children. In fact, it's the most frequent cause of nephrotic syndrome in the pediatric population. This is characterized by normal microscopy. That is, if you look at a normal hematoxylin and eosin stained section of a glomerulus from somebody with minimal change disease, it will look absolutely normal. And that's where the name comes from. It has only minimal changes that can be detected only upon electron microscopy. On electron microscopy, what you see is a diffuse loss of the epithelial foot processes which abut the basement membrane where the protein is filtered. The clinical features of this are that the children normally respond to a course of steroids, suggesting that there's an inflammatory or autoimmune component to this disease, and the majority of them have a complete recovery. Here's some schematics, an EM picture and a schematic diagram of what minimal change disease looks like. You can see in the EM picture that there's a capillary with a basement membrane, and where you would normally see regular foot processes with gaps in between, you see diffuse effacement of the foot processes such that there's only gap now. And in some way, this blocks the ability of the glomerulus to prevent protein entering the urine. In the schematic diagram, you see the same thing. You see effacement of the foot processes, and this allows filtration of protein from the plasma into the urinary tract. A second cause of nephrotic syndrome is focal segmental glomerulosclerosis, and the name tells you everything you need to know about this disease. Glomerulosclerosis means hardening or fibrosis of the glomerulus. Segmental means that it only affects a part of each glomerulus, and focal means that it only affects some glomeruli. Now, this disease occurs very frequently in the African American population and less in other ethnic groups. It's associated in some cases with HIV, with heroin use, with sickle cell disease, and with obesity. What happens in this disease is very similar to what you see in minimal change disease, except the changes are more evident on light microscopy. There is effacement of the epithelial cell foot processes such that it allows spilling of protein from the plasma into the urine. Unlike minimal change disease, however, this shows a poor response to corticosteroids and is more commonly progresses to chronic renal failure. Here's a picture of what it looks like. You can see on the right here that you have a part of a glomerulus which shows sclerosis, which shows hardening or fibrosis of the glomerulus. And you can see that by the deep eosinophilic portion of that glomerulus. And this is characteristic of focal segmental glomerulosclerosis. Another cause of nephrotic syndrome is membranous glomerulonephritis. This is actually the most common cause of nephrotic syndrome in adults. It has a very high incidence, especially in teenagers and young adults. On light microscopy, what you see is a diffuse thickening of the glomerular capillary wall. And that formation of that membrane is where membranous glomerulonephritis gets its name. If you look at the electron microscopic level, what you see is an accumulation of immunoglobulin-containing deposits along the basement membrane. And this causes the formation of what we call a spike and dome type formation, which I'll show you in a picture in just a minute. The spikes are actually the basement membrane. The domes are the deposition of these immune complexes along the basement membrane. If you do immunofluorescence, what you see is a granular deposition of both IgG, which is the immunoglobulin, and C3 complement proteins along the basement membrane. This is a general characteristic of all immune complexes diseases, which we'll see several other types as we proceed through this lecture. Now, this is associated with several different things, different kinds of drugs, including things like penicillamine, captopril, gold that they use to treat rheumatoid arthritis, and nonsteroidal anti-inflammatory drugs can cause this. Malignancies of the lung, colon, and skin, systemic lupus erythematosus, or SLE, can cause this. Certain infections and metabolic diseases can lead to this particular type of nephrotic syndrome as well. This is very likely to progress. The prognosis is usually grim. It rarely responds to steroid therapy and usually ends in end-stage renal disease. A clinical association that you can see with this disease is renal vein thrombosis, leading to complete obstruction of the renal vein. Here's a picture of what it looks like. You can see in the H&E stain section on the left that you have diffuse thickening of the glomerulus. And so it forms these membrane-type, brightly eosinophilic membranes throughout the glomerulus. And you can see that that's where the disease then gets its name. If you look at the electron microscopic level, you can see that the basement membrane is punctuated by these dark humps of immunoglobulin deposition. They're these darker lobules that you see within the basement membrane. And that's the spike and dome type formation that I described earlier. Now here's a picture of immunofluorescence. What this is detecting is immunoglobulin and C3 complement protein that's been deposited through the subendothelial area, or the subepithelial area. And that lights up on immunofluorescence, creating this sort of lumpy, bumpy immunofluorescence type pattern. A fourth type of nephrotic syndrome is what we call membranoproliferative glomerulonephritis. This is characterized by thickening of the basement membrane itself and proliferation of the primary glomerular cells. The characteristic appearance on EM that you see in this is what we call a tram track appearance, where you've got interruption of the basement membrane by these lobules of antigen-antibody complexes. Now, this can be both a primary or a secondary disease. Usually it's caused by immune complexes which are deposited in various types of both infectious and autoimmune diseases like lupus, like hepatitis virus infection, like HIV. You can also see it in certain neoplasms like lymphoma, like chronic lymphocytic leukemia, or melanoma. The clinical features of this disease are both a nephrotic syndrome and a nephritic syndrome. We've already told you what a nephrotic syndrome is, where you spill protein into the blood. Nephritic syndrome we'll describe in a few minutes, but this can have either a nephrotic or a nephritic picture, or it can be mixed with features of both of those diseases. You characteristically see decreased serum C3 complement protein in this particular disease because it's consumed in forming these immune complexes. The prognosis of this disease, like some of these other diseases, is very poor. You have a slowly progressive course to end-stage renal disease. Chronic renal failure typically develops over about a decade. Now, there are two basic types of membranoproliferative glomerulonephritis that are distinguished by their appearance on electron microscopy. The type 1 gives you this typical tram track type appearance with subendothelial electron-dense deposits. Now, it's important to distinguish this from what you see in membranous glomerulonephritis, where the electron-dense deposits are on the subepithelial side of the basement membrane. Here we have subendothelial electron-dense deposits that give you this tram track type appearance. In type 2 membranoproliferative glomerulonephritis, you actually see the dense deposits in the lamina densa of the basement membrane itself. And so the tram track appearance is less striking in type 2 disease. So here's a picture of what this might look like. In type 1, you can see schematically that you have subendothelial deposits, that is on the endothelial side of the basement membrane, whereas in the type 2, you actually have deposits within the basement membrane itself. And you can see that depicted in the electron microscopy here. On the left, you have type 1 with the subendothelial deposits. On the right, you have the type 2 with the intra-basement membrane deposits. A fifth type of nephrotic syndrome is what you see in people with diabetes mellitus, what we call diabetic nephropathy. What happens in diabetic nephropathy is people with chronic high glucose concentrations in their blood end up having non-enzymatic glycosylation of proteins. And these proteins deposit in the matrix of the glomerulus. And this leads to problems, obviously, derangements of the physiology of the glomerulus. Clinical manifestations of this disease start with what we call microalbuminuria. That is, detection of small amounts of albumin or protein in the urine. This progresses slowly over time until the protein that's being released into the urine is actually in the nephrotic range, that is greater than 3.5 grams per 24 hours. As this progresses, they progressively develop worse and worse hypertension and progress slowly to end-stage renal disease. What you see in this disease is thickened glomerular basement membranes on electron microscopy and thickening of the vascular glomerular basement membrane. And these are particularly common in diabetes mellitus. In addition, you see an increase in mesangial matrix, and this produces what we call Kimmel-Still-Wilson nodules, which I'll show you in a picture here. You can see that there's an increase in the matrix and even the formation of these eosinophilic nodules within the matrix itself, the mesangial matrix. And this is what we call the Kimmel-Still-Wilson nodules. You can see on the left that there's deposits within the basement membrane and proliferation of this mesangial matrix, which leads to the problems in diabetic nephropathy. A final type of nephrotic syndrome is due to a disease that we call amyloidosis. Amyloidosis is caused by deposition of abnormal proteins in many parts of the body. In the kidney, what you see are subendothelial and mesangial deposits of amyloid protein. Now, typically the way that you detect this is by Congo red staining. If you apply a Congo red slide to a section of kidney that has amyloidosis, and then apply polarized light to it, what you'll see is apple green color, what we call an apple green birefringence of this particular deposit. Now, you can see this in a lot of different situations, but typically chronic inflammatory diseases are the most common situation in which you see amyloidosis. You can also see it in things like plasma cell myeloma as well. We'll talk more about this when we do the amyloidosis lecture. Now, we just finished talking about six different causes of nephrotic syndrome. And I told you earlier that the main feature of nephrotic syndrome is a defect in the glomerulus such that you're releasing protein into the urinary system. Nephritic syndrome, on the other hand, is characterized by hematuria, that is, filtration of red blood cells into the urinary system. Typically, the glomerulus prevents the passage of any cellular material from the blood into the urinary tract. But in nephritic syndrome, you have defects in that glomerulus such that the cellular components, including red blood cells, are now released into the urinary tract, and the consequence of that is hematuria. You also see what we call red blood cell casts, which you can see if you look at the urine microscopically. You can see red blood cells that are all smashed together and form tubular structures. These are called red blood cell casts. Now, the clinical features of these diseases are hypertension, azotemia, which is an increase in the blood urea nitrogen. You see oliguria, which is decreased urine production. And you can see proteinuria, but it's usually not in the nephrotic range. That is, it's less than 3.5 grams per day. Now, the nephritic syndromes tend to be more severe and more rapidly progressive than the nephrotic syndromes. In fact, the nephritic syndromes may actually progress to what we call rapidly progressive glomerulonephritis, which is characterized by acute nephritis, that is acute inflammation of the kidney, proteinuria, and acute renal failure, that is renal failure in a very short period of time. Now, one of the causes of nephritic syndrome is what we call post-streptococcal glomerulonephritis. Now, post-streptococcal glomerulonephritis, as the name implies, is a type of nephritic syndrome that develops after somebody has a streptococcal infection. Usually about 2 to 4 weeks after recovery from a group A beta hemolytic strep infection, they'll develop malaise, fever, nausea, oliguria, which is decreased production of urine, and hematuria, which is blood in the urine. They may also have a mild proteinuria. They may develop periorbital edema as a consequence of hypoalbuminemia and hypertension. The damage in this case is due to antibody-antigen complexes. What happens is some molecular mimicry. Some of the antibodies that develop against the group A strep may actually cross-react with antigens that the body normally produces. These antigens and antibodies get together and form complexes which deposit in the kidney and cause the problems associated with post-streptococcal glomerulonephritis. In electron microscopy, what you see are subendothelial deposits of these antigen-antibody complexes, creating humps on electron microscopy. If you do immunofluorescence, similar to what we saw in some of the nephrotic diseases, what you see is IgG and C3 complement protein lighting up in a coarse, lumpy, bumpy type pattern. On routine laboratory studies, what you'll see is red blood cell casts in the urine. You'll see azotemia, which is increased blood urea nitrogen. You'll see decreased serum C3 complement proteins because they're being consumed in these antigen-antibody complexes, and increased titers of antistreptococcal antibodies, most particularly the antistreptolysin O or ASO type antibodies. Clinical features of this disease in children, there's typically a complete recovery in greater than 95% of the cases. Adults don't do as well. They only completely recover in about 60% of the cases. And a subset of those who don't recover may progress to this rapidly progressive glomerulonephritis that I described earlier. Now, it's not only streptococcal infections that can cause this type of acute glomerulonephritis. You can see it in a host of infections that are listed here. The etiology is, or the pathophysiology is the same. It's just that the etiologic agent may be different. And these are called non-streptococcal acute glomerulonephritis. Now, here's a picture of what it looks like. On the left, you see a normal glomerulus. On the right, what you see is glomerular hypercellularity. Now, this is due to inflammation within the glomerulus itself. You see increased intracapillary leukocytes, and you see proliferation of the intrinsic glomerular cells, such that you have a very hypercellular-looking glomerulus. On electron microscopy, what you see is what I described earlier, these characteristic subepithelial humps, which you can see is this electron-dense area right here, that consist of these antigen-antibody complexes deposited in the subepithelial part of the basement membrane. Now, a second cause of nephritic syndrome is what we call IgA nephropathy. And this is actually the most common cause of glomerulonephritis worldwide. This is characterized by deposition of IgA in the mesangial matrix. Clinically, what you see is, again, after an infection, you'll see the production of gross hematuria. So microscopic hematuria is where you can't see it, but the red blood cells are there microscopically. Gross hematuria, the urine will actually be red. That is, the patient will be able to see blood in their urine. Now, this will often last for several days. It may have a relapsing and remitting course where it recurs every few months. And about a quarter to a half of these patients will slowly progress to chronic renal failure. Now, this type of IgA nephropathy can be a component of a disease that we'll discuss a little bit later, called Henoch-Schönlein purpura. Here's some pictures of what IgA nephropathy looks like pathologically. What you see here is deposition of material in the mesangial matrix. So you can see that there are eosinophilic deposits focally throughout the glomerulus. On immunofluorescence, if you use an immunofluorescence antibody against IgA, what you'll see is these mesangial depositions of IgA, again, focally throughout the glomerulus. Now, there are also hereditary causes of nephritic syndrome. An example of this is what we call Alport syndrome. Alport syndrome is most commonly an X-linked disease. It's caused by a mutation in the alpha-5 chain of type 4 collagen. Now, you may remember from other lectures that type 4 collagen is the type of collagen that we see in basement membranes. And so a defect in type 4 collagen will lead to disruption of basement membranes and allow filtration of things that normally shouldn't get through the basement membrane. Now, what you see in this disease is a hereditary nephritic syndrome. You also see defects in other tissues as well, leading to nerve deafness and ocular disorders, most commonly lens dislocation and cataracts. So if you see a situation in which a patient develops nephritic syndrome and renal failure in conjunction with deafness and ocular disorders, you'll be looking for Alport syndrome. Now, all of these nephritic diseases can end in what we call rapidly progressive glomerulonephritis, as we've already described. This is clinically defined as a nephritic syndrome that progresses very rapidly, meaning it progresses in weeks instead of months to years like most of these renal diseases do. The patients with this disease present with hematuria, they get red blood cell casts in their urine, and moderate proteinuria. Now, there's a typical feature that you see on light microscopy that you only see in RPGN, and that is the formation of fibrin crescents developing between Bowman's capsule and the glomerular tuft. And sometimes this disease is called crescentic glomerulonephritis because of the characteristic crescents that form. And a picture of that is shown in a later slide. This has a particularly poor prognosis. It rapidly progresses to end-stage renal disease requiring dialysis or transplant, or else leads to death. Now, there are three types of diseases that can cause rapidly progressive glomerulonephritis. The type 1 is the anti-glomerular basement membrane diseases, which can be either idiopathic or associated with Goodpasture's disease, which we'll describe in a second. The second type are the immune complex-mediated diseases that we've already described, like post-streptococcal glomerulonephritis, IgA nephropathy, Hennig-Schönlein purpura, which we'll describe later, and systemic lupus erythematosus, which we'll describe later as well. A third type that we haven't talked about yet are what we call the posse-immune diseases, and these are characterized by the presence of a particular type of antibody, which is an anti-neutrophil cytoplasmic antibody, or ANCA. And these are things like Wegener's granulomatosis and microscopic angiitis, which we'll describe again in a few minutes. Here's a picture of what rapidly progressive glomerulonephritis looks like. You can see the formation of these crescents, which are these eosinophilic deposits, again, between Bowman's capsule and the glomerular tufts. And the formation of these crescent structures is characteristic of rapidly progressive glomerulonephritis. So let's talk about each of these three types in turn now. The prototype of the anti-glomerular basement membrane diseases is Goodpasture syndrome. Goodpasture syndrome is an autoimmune disease in which anti-glomerular basement membrane antibodies are formed such that you get an autoimmune reaction against basement membranes, both in the glomerulus in the kidney and also in the pulmonary alveoli. And so this is a combination of both renal and pulmonary disease. Now, because of the deposition of these antibodies, what you'll see on immunofluorescence is a very linear type picture, as opposed to the lumpy, bumpy appearance that you see in antigen-antibody complex deposition diseases. The difference is that these are antibodies directly against the basement membrane, rather than complexes depositing in or near the glomerular basement membrane. Clinically, what you see in these patients is typically a male patient in his early 20s is when they typically present. They'll have nephritic syndrome, that is, they'll have oliguria, hematuria, and so forth. In addition to that, they'll have pneumonitis. They'll have pulmonary symptoms, including hemoptysis. This is one of the diseases, again, that can progress to rapidly progressive glomerulonephritis and acute renal failure. We've talked about some types of immune complex-mediated diseases already, including post-streptococcal glomerulonephritis and IgA nephropathy. Another type of this disease is what you see in systemic lupus erythematosus, or SLE. Now, SLE-related kidney disease is very heterogeneous. There are basically 5 types of disease that can present as nephritic syndrome, nephrotic syndrome, or a combination of both. Type 1 is where you see no renal involvement at all. Type 2 is a mesangial form, in which predominantly what you see is expansion of the mesangial matrix, both in cellular forms and in deposits in the mesangium. Here you see a slight proteinuria and minimal hematuria, not very severe. Types 3 and types 4 are proliferative forms, in what you see is subendothelial immune complex deposits and thickening of the basement membrane. Now, the difference between type 3 and type 4 is that the type 4 is diffuse, meaning it occurs throughout the glomerulus, where type 3 is focal, meaning it only occurs in a part of the glomerulus, or only in a few glomeruli in the kidney. Type 5 is what we call membranous, and it's essentially the same as primary membranous glomerulonephritis. Another type of immune complex mediated RPGN is what we call Hennig-Schönlein purpura. This is characterized by purpuric skin lesions, which involve the extensor surfaces of the arms, legs, and the buttocks most typically. This usually occurs in childhood, and it's caused by deposition of IgA, IgG, and C3 complement protein in the mesangial region. At least that's the renal manifestations of the disease. Clinical features include things like abdominal pain, vomiting, intestinal bleeding, non-migratory arthralgias, meaning arthralgias that stay in the same place, stay in the same joints, and then this palpable purpura on the legs and buttocks. And again, this is an autoimmune disease, the manifestations in the kidney of which are deposition of immune complexes in the basement membrane. Now, there's a third type of these RPGN-type nephritic diseases that are the posse-immune diseases, and again, these are the ANCA-positive diseases. ANCA, again, stands for anti-neutrophil cytoplasmic antibodies, and they occur in 2 forms. There's the paranuclear type staining, where you see staining of ANCA around the nucleus, or the cytoplasmic, in which you see ANCA more diffusely throughout the cytoplasm of these cells. The paranuclear forms include autoimmune diseases like polyarteritis nodosa, Sturge-Strauss disease, and microscopic angiitis, which are described in the autoimmune lectures in pathology. The cytoplasmic form is Wegener's granulomatosis. Here you see focal necrotizing vasculitis and necrotizing granulomas in the upper airway, lung, and necrotizing glomerular nephritis. Clinically, they'll have combinations of the features of each of these defects. You'll have perforation of the nasal septum. This is from granulomatous inflammation of the upper airway. You'll have sinusitis as a result of that as well. Cough and hemoptysis is from lung involvement. And you'll get red cell cast and nephritic syndrome due to kidney involvement. Now, all of these diseases, whether they be nephritic or nephrotic, have their endpoint in what we call end-stage renal disease. And this is where much of the normal glomeruli of the kidney have been destroyed, such that there's no longer hardly any normal renal function. Pathologically, what you see are shrunken kidneys. They shrink as they lose glomeruli. And you see what we call thyroidization of the kidney. The kidney starts to look like a thyroid because all you see are tubules with no glomeruli, which are sort of reminiscent of the follicles that you see in the thyroid. And a picture of that is shown here. So this ends the section on glomerular